Hey, my name's Katie. I'm an intern at Nepean Hospital this year, and I've spent the first 5 months of internship on the acute surgical unit. This presentation is aimed to help you assess post-operative patients, as a lot of your work as a surgical JMO, or especially working on after hours, will involve you assessing deteriorating patients and trying to figure out why this may be occurring in their particular case. And for this presentation, I've targeted this to surgical patients. Firstly, I'm going to present some broad differentials for you about some common calls you might receive for post-operative patients, and then we'll work through a few cases of patients that I've seen this year that I think demonstrate the way in which you might choose to work up a surgical patient who you might be concerned is deteriorating. So why might you get called to review a post-op patient? The main reason will be for any derangement in vital signs, so that's any observation that's not within the flags. And this alert system is really well set up to let us recognise deteriorating patients early. Some other reasons might be low urine output, decreased GCS, high or low blood sugars, and rashes. I'm probably going to focus most on the first two today in the examples that I'll give you, but it could be for any of these reasons. When you first come to review a post-op patient, like any patient, I would recommend doing an A to E assessment. So the first thing that you do is to look at their airway. If you suspect any kind of compromise or obstruction, you can begin to perform airway manoeuvres like a chin lift and jaw thrust. However, you're going to need further help and you should really be calling a MET call in a circumstance like this. Most patients that you can speak to and they can answer you in sentences can confidently be assessed as having a patent airway. Moving on to breathing, you should assess their respiratory rate, their oxygen saturations, see what kind of oxygen therapy is being given, if any, so looking at the flow rate and the mode of delivery. You should listen to their chest, assess for air entry and for any extra sounds on auscultation. In terms of circulation, you should assess their heart rate, blood pressure and their pulse. You should look at their capillary refill. This is best assessed centrally, so over their sternum. And you should also feel their peripheries to check that they're warm and well perfused. Disability, it depends on the kind of call. If it's a call about a decrease in GCS, then you should of course perform a formal GCS at the time of review. But for most patients, if it's not a neurological primary complaint as the reason for why you're seeing them, then you should probably be okay just checking that the patient is alert and orientated. And then in terms of exposure, you should check the patient's temperature and you may need to more adequately expose them to perform the rest of your examination. The next thing is to assess the presenting symptom or the presenting change in vital sign, and that's by taking an adequate history. You should ask about relevant symptoms to this change in vital sign and try and assess their medical background and any medications that may be relevant to this particular presentation. The next step is examination. You should recheck the patient's vital signs as they may have changed since you were called to review them, and if they've improved or worsened, it might steer you in different directions of management. The next thing you should do is a general inspection. You should see whether the patient looks well or unwell and in any obvious pain. You should also look at any lines connected to the patient, so you should look at any sources of inputs, whether they have things like cannulas or central lines or PICC lines, and what's running through them. So are they being administered fluids? Are they being administered TPN, so nutrition through the drip, or any NG or NJ feeds? And you should look for any outputs they have, so any NG outputs, any surgical drains that might be in their abdomen or any other surgical site. They may have a IDC in, so you should see what's coming out of the catheter, the colour of the urine, or anything that might be concerning. You could also look at their stoma. Some general surgical patients may have an ileostomy or a colostomy, so assess that as well. The next thing is to look at the most relevant kind of examination to the particular symptom or vital sign. So for a lot of general surgical patients, this might be an abdominal examination. But you should really do a full targeted systems review for all patients, so that includes listening to their heart and lungs, feeling their abdomen, assessing their fluid status, and looking at their calves to make sure that they're soft and non-tender. In terms of assessing the fluid status, this involves looking at their mucous membranes to check if they're dry or moist, assessing their cap refill, their tissue turgor, their urine output if you're able to look at that, and also looking for any signs of edema. You should listen to their heart and lungs and look for any signs of ascites. So the next thing I would recommend is to really use the notes to your advantage. Looking at the documentation throughout a patient's entire stay can really help you to piece together the puzzle of what's going on. You should look at things like the operation report. What operation did the patient have? Did anything go wrong that might cause you particular concern? And look at what day that operation was on, because the amount of days post-operative that they are can really change what kind of complications you're worried about. You should also look at the trends of their vital signs, so you can assess it throughout their entire stay, and especially within the last 24 hours, to kind of see whether it's a new change that they've had or more of a chronic problem. You should assess their inputs and outputs. It's not always formally documented, but for a lot of surgical patients this is really well documented, what they've been given and what kind of outputs they're having, and it can help you to assess their fluid status and look for any concerning outputs, for example, a lot of fluid out of their drain or out of their NG tube. And next, you should also look at any recent bloods and imaging that might be relevant to the particular case. So when I'm talking about derangements in vital signs, I think these are definitely things that you're aware of, but it's going to be high or low blood pressure, heart rate, respiratory rate, temperature, and any decrease in oxygen saturations. The ones that I've highlighted in red, I think, are the most common calls you'll get for a surgical patient, and they're the ones that I'm going to discuss some broad differentials with you in more detail. The differentials I've thought of are not an exhaustive list, but I think key things to work through for surgical patients when you're just trying to think of what could be going on for them. So the first one I'll discuss is hypertension. You should assess their symptoms and rule out any life-threatening conditions where hypertension may be present. So the things that are really concerning would be aortic dissection, MI or stroke, or any symptoms that are related to hypertensive emergency, so severe headache and any vision changes that might kind of imply that the hypertension is causing bleeding or causing a problem for this person. So you should ask them about abdominal pain and back pain for aortic dissection, any chest pain, and any headache or neurological symptoms. For most patients, hypertension in hospital can be due to pain, withholding usual medications, or a stress response just because they're unwell. You should see what kind of analgesia they're on and whether there's anything that you could give them in aid to this, or encourage them to use medications that are already charted for them. A lot of patients will come into hospital on antihypertensives and they may be withheld because they're nil by mouth or they've had episodes of hypotension, but sometimes that can mean that when those medications are not given, the patient becomes hypertensive. Hypotension will be one of the more common reasons why you get called to review a surgical patient. And I like to think about the causes of shock and then work through these as differentials for why they might be presenting hypotensive. The first thing is to assess if they're hypovolemic, as this is the most common reason why surgical patients will be hypotensive. What you're most worried about is that they're having bleeding, but that you should also be worried that they are fluid depleted and may need further IV fluid resuscitation. The next thing would be distributive shock. So they may have septic shock following an infection, or they may have anaphylactic shock, and this could be caused by anaesthetic agents or antibiotics or any other medications that's been given to them while they're in hospital. In terms of obstructive shock, probably for surgical patients, the thing you'd be most worried about would be a PE. Surgical patients are immobilized, and have had trauma to a certain area, so they're at high risk of having a DVT and a PE. Cardiogenic shock is something that is probably more seen in cardiac patients, but you should always remember that surgery can cause a big insult on a person's body, and they're more at risk of having ischemia due to a demand and perfusion mismatch. And that's something, for example, a type 2 MI may happen following surgery because the demands of a patient's body just can't be met by a person's heart, and it can cause ischemia within their myocardium. In terms of endocrine causes, again, probably less common, but always consider surgical patients who are steroid dependent, that they may not be receiving adequate steroids to really mount a response to their recent surgery. So consider Adansonian crisis in patients that are steroid dependent. And lastly, neurogenic shock. This is obviously a big concern for neurosurgery patients, and it's a really worrying cause of hypotension, so you need to get help if you think that this is the primary cause. Tachycardia. Remember, this can always be an early sign of shock developing, as it's your body's way of trying to increase cardiac output. There can be cardiac causes of it. Tachyarrhythmias like AF surgery and electrolyte derangement can sometimes cause someone to go into acute AF. And then things like atrial flutter or other tachyarrhythmias might also be present. Probably for most surgical patients, the reason they're tachycardic will not actually be a cardiac cause, but more a response by the body to things like hypovolemia, sepsis, a respiratory cause, so like PE, pneumonia, and pneumothorax. It can also be caused by pain or anxiety, and these are probably really common reasons for tachycardia, but you should always rule out the life-threatening causes first. Tachypnea can be caused by an acute respiratory problem. So in surgical patients, you're worried in the early days about atelectasis. Their lung bases can collapse because they're lying down in bed all day and not really moving around and allowing their lungs to adequately fill. And later on in their course, they may also develop pneumonia for similar reasons. Like I mentioned before, PE is always a concern for surgical patients. If they have an NG in place, always think that there's a possibility that it might be in the wrong place and has actually gone down into the airway. And in trauma patients, you should consider things like pneumothorax and rib fractures as causes of tachypnea. Again, I repeat, sepsis, but it can cause derangement in most vital signs, and pain and anxiety again can cause people to breathe fast, but you should always think about other more life-threatening causes first. Hypoxia has a number of different causes. Just some things that I think you should be aware of for surgical patients is that they're likely to be on anaesthetic agents or opioid medications, and these might reduce the patient's respiratory drive. And also you should see whether the O2 saturations that we're aiming for are actually appropriate for the patient. A lot of patients in hospital do have COPD, and for these patients that retain CO2, we usually aim for saturations of 88 to 92%. So just make sure that the saturations that we're aiming for are actually appropriate for the patient. Another really common call, post-op fever. You might have heard of the 5 Ws as ways to work through why a person might be post-operatively febrile. I think they're wind, water, wonder drugs, wound, and walking. I like these 6 Cs a bit more because I think that they cover the causes a bit better, but whatever works for you to remember. Basically, you're looking for any possible source of infection and then thinking about PEs because they can also cause fevers. In terms of a person's chest, you're worried about atelectasis or pneumonia as a cause for fever. You might be worried that because they've had a catheter in that they might be at risk of a urine infection. They may have an infected line like a cannula or a PIC. They may have an infected surgical wound, so a cut, or they may have a collection. This is really relevant for people having abdominal surgery, and you should always think about anastomotic leaks for patients that have had bowel resections. So if their anastomosis hasn't really healed, where they've joined 2 pieces of bowel together, there's always potential for bowel contents to leak out into the abdomen and cause a febrile response to that infection. And lastly, like I said, to assess their carbs for DVT or PE. The timeline of a person's fever is really important because it can lead you towards different diagnoses. It's not a strict timeline, and different things can happen in different people at different times. But you should think about early fever after an operation, so days 1 to 3, is more likely to be caused by things like atelectasis, procedures in the operation itself, so instrumenting a viscus can cause a febrile response, as can a septic shower from an infection seeding during an operation. For example, if you were taking out someone's appendix and it perforated mid-operation, it may be a response to that. Then further along, maybe day 4 to 6, you're more likely to see pneumonias developing, wound infections and UTIs. And then even later down the course, so day 6 to 7, is when you're worried about an anastomotic leak or a PE. And remember, they could have an infected cannula that's causing a fever or an infected line at any point in time. Now we're going to work through some cases. So the first one that I'd like to work through with you is a 46-year-old male who's day 5 post-appendicectomy. He's febrile and tachycardic is why you get called, and you just know that he has a history of type 1 diabetes. And throughout all these cases, I really encourage you to pause this video and have a think about, at each stage of information that we have, what you might think the differentials will be and how they change as we get more and more information. Because it's really good for you to consider your own differentials list as we're working up these patients. So to assess his airway, he's speaking in sentences, his breathing, no issues really, respiratory rates normal, and so are his oxygen saturations, normal auscultation. His heart rate is concerning at 130, blood pressure normal, and it looks like he's well perfused, so normal cap refill, he's warm with a strong pulse. GCS 15, and temperature 38.9, so again, concerning fever. His history is that he said he's had worsening pain since the operation in the right iliac fossa. He's been feeling nauseous and hot and cold with some shakes and rigors. When you examine him, he looks really uncomfortable. He's diaphoretic. He has a cannula in situ that's got some surrounding erythema. He's complaining of a lot of tenderness in the right iliac fossa, and he has localized guarding. He has no signs of peritonism. His wounds look clear. He's got 200 mils of purulent output coming from the drain in his right abdomen, and that's the recorded amount in the last 24 hours. His heart and chest both sound normal, and his calves are soft and non-tender. When you look at the notes, you see that he's had the operation and that it involved perforated appendicitis with pus in 4 quadrants of the abdomen. So that's really raising your concern of an intra-abdominal infection or collection because there was bowel contents that has leaked into the abdominal cavity. He's had several low-grade temperatures since the operation. The highest before this one was 37.8, and he's had BSLs that have been higher than usual post-operatively, so running between 10 and 14 for him. He usually has really well-controlled type 1 diabetes. And that's probably something of concern because you're worried that there's an infective cause that might be driving his blood sugars to continue to rise due to cortisol increasing. So differentials at this point. Look, you can come up with your own differentials. These are mine. I think at this point in time, I'd be most worried about an intra-abdominal collection, mainly due to the fact that he's both tachycardic and febrile, and that the main source of his pain is in his right iliac fossa. You've also got the sign of pus coming out of that drain, so it looks like his abdominal cavity is not particularly clean. Other things you should think about are a PE. It's about the right time period for you to be worried about a PE. It can cause both fever and tachycardia. However, I think given the abdominal findings, it's maybe a bit less likely to be the primary cause. He's also got no chest pain and his calves are soft and non-tender, and he's been mobilising around the ward during this period of time and has been on DVT prophylaxis. Think about other sources of infection. Sometimes because a patient's been post-op and their abdomen's sore because they've had an operation there, you might miss other reasons why they could be mounting a fever. So think about things like pneumonia, UTI, and their wound, and all the other 6 C's that I spoke about earlier. DKA is always going to be a concern in this patient. It's less likely to happen in hospital, as for diabetic patients, we closely monitor their blood sugars and give insulin as needed when they become out of range. But always think about it, and it can often be brought on by an infection, so keep it in the back of your mind for patients with type 1 diabetes. So the investigations that I would order would be bedside tests, a BSL and an ECG. An ECG is usually relevant for most patients with tachycardia to see whether it's a cardiac reason or whether it's sinus tachycardia. You should order bloods. So for him, I would order a full blood count, electrolytes, a CRP and a VBG. You should look at sending off cultures. He needs to have a septic screen done, and that involves taking blood cultures, taking a urine culture, having a chest x-ray to look for pneumonia. And because his cannula looked a bit dodgy and had redness around it, you should take out that cannula, but you should consider sending that cannula tip for culture if you're suspicious that that could be causing the infection. He may need an abdominal CT to look for any collection that's formed after his operation, but I would discuss that with the surgical registrar before you order it. So looking at his blood sugar, it's 14. His ECG shows sinus tachycardia. When we look at his bloods, his hemoglobin's normal, white cells and CRP are consistent with quite a severe infection. His VBG is normal. You've sent off the cultures, but usually it takes a day or two for those to return and give you what bugs are growing and sensitivities, but it's important to send it off as soon as you can. His chest x-ray is normal, and you discuss his case with the surgical registrar who agrees that he should have an abdominal CT. It shows a rim-enhancing fluid and gas collection that's abutting the cecum, so it looks like he's developed a collection nearby to their surgical site. This is not from the particular patient that I saw, but this is a similar CT scan that just shows a collection that's formed in this area near the person's cecum, and you can see gas locules within the collection. So what would you do to manage someone who you think has an intra-abdominal collection? So you need to manage the person's pain, give them adequate analgesia as it's likely to be causing them quite severe pain. You should administer antibiotics. They're probably already on antibiotics if there was perforated appendicitis and they've been in hospital for a few days afterwards, but if not, they definitely need to be on antibiotics. It should be an empirical choice until the cultures return from the collection. For a lot of surgical patients, you're looking at something like IV augmentin or a combination of ceftriaxone and metronidazole, but be guided by your hospital's local policy, and you can always chat to infectious diseases to get their advice in a particular case. You should keep this patient nil by mouth and administer IV fluids for surgical review, as they may need urgent operative management. For this patient, he would probably have a laparoscopic washout and drain insertion. So that involves going back into the port sites where the laparoscopic appendicectomy was done and really washing out the abdominal cavity to try and remove any pus or any brewing infection that's happening within the abdomen. And he already had a drain inserted, but if there wasn't one, then you would definitely put in a drain to try and drain out any further fluid or pus that's collected in the abdomen. Depending on the size and location of the collection, sometimes you don't actually need to go back in and have an operation. We're moving towards a lot of CT or ultrasound-guided percutaneous aspirations or drain insertions of abdominal collections. It's less invasive and allows for a similar effect in many patients because we're still allowing that collection of pussy fluid to come out of the abdomen. So the next case is looking at a 54-year-old female. She's day 2 post-laparoscopic cholecystectomy. And you get called because she's tachycardic, hypotensive, tachypneic, and has a low-grade temperature. The only past medical history that she has is a gastric sleeve 9 months ago. So this is pretty concerning, as many of her vital signs are showing derangement. So when you do your A to E assessment, her airway is patent, her breathing is normal, her circulation shows tachycardia, a blood pressure of 95 on 60, a capillary refill of 4 seconds. Her peripheries seem a bit cool, but she has a strong regular radial pulse. Her GCS is 15, and her temperature is mildly elevated to 37.8. So she has really severe pain in the right upper quadrant, and this has happened since her operation but has been getting acutely worse. When you examine her, she's crying in pain. She has a cannula in situ, and she's currently having IV augmentin being administered through her cannula. She's very tender in the right upper quadrant and has localized peritonism. Her wound sites all look clean, her heart and chest are normal, and her calves are soft and untender. When you look at what's happened in her operation, you can see that she had a gangrenous gallbladder, so it had probably been brewing an infection for a little bit of time and had become necrotic in patches, and she's on no regular medications. So I guess at this point in time, you're quite worried about this person because they're hypotensive and they have this localized peritonism. So it looks like they are having an acute problem in their right upper quadrant. So what investigations will we do for this patient? I would think that a blood sugar and ECG would be the most appropriate bedside tests. Again, moving on, I would do bloods, cultures and imaging. So for bloods, full blood count, electrolytes, CRP, VBG and LFTs in her case. She should have cultures sent off as part of a septic screen, so blood cultures, urine culture and a chest x-ray for that septic screen. The CT scan will depend, again, you should chat to a surgical registrar or the surgical team. She may need a CT Chol Angiogram. That's a way of assessing for a bile leak by inserting a type of contrast that collects in the biliary drainage system and can look for any extravasation of that contrast into the abdominal cavity that might suggest a bile leak. But they also might want to do a CT angiogram if they're worried about bleeding, or they may want to do a normal CT abdo-pelvis to look for any collections. So discuss with them, but she'll definitely need further imaging or further surgical management. So the results of these, her blood sugar and ECG are done, just shows sinus tachycardia and normal blood sugar. Her bloods, her hemoglobin is stable from before the operation, which lessens the likelihood of an intra-abdominal bleed. Her white cell count and CRP are up. Her EUCs are normal. She has an increased lactate, which you can see in patients that are in lactic acidosis, again making you concerned that she's in a septic state. Her LFTs are mildly deranged, and her bilirubin is, let's say, 10, so not something that you're particularly concerned about as being cholangitis as the cause of her pain. However, you can often see LFT derangement in people who've recently had biliary surgery or have had a bile leak, as it can cause irritation around the liver. And then looking at blood cultures and urine culture, again, you've sent them off but you don't know where they've grown. Chest x-ray is normal. You decide to do a CT cholangiogram, and it shows a bile duct leak. And I'll show you what this looks like. So I'll just show you an example of an image of a CT cholangiogram. And it's showing that there's this particular one, so you can see contrast in the biliary drainage system that's coming out into the abdomen, that's making you think that there is a defect in the biliary drainage system and a bile leak occurring with some fluid kind of collecting around that area too. So what do we do for patients who are having a bile leak? It would depend on how severe their leak is, but for any patient, they're going to need analgesia, antibiotics, and especially in this case where this person is presenting septic, you will need to have IV fluid resuscitation. So I would give them 500 to 1,000 ml bolus of normal saline or Hartmann's, and then reassess their blood pressure for ongoing need for fluid resuscitation. They would need to be kept nil by mouth for surgical review, and the team will probably be aware of them because you've asked them about this CT scan, but they definitely need to be seen urgently by a surgical team. There's lots of different managements that can happen for bile leaks. For severe cases where you're worried that there's quite a lot of bile that's leaked into the abdominal cavity, then you should perform a laparoscopic washout and drain insertion. So get rid of all the bile that's sitting in that abdominal cavity and insert a drain for any further bile to leak out. I guess the issue with bile leaks is that because there's a defect in the biliary drainage system, the bile will leak out into a lower pressure area. So that is usually the abdominal cavity. In order to redirect the flow, you can put a stent into the biliary system via ERCP. So, for example, if it's a cystic duct stump leak, you can kind of put it across that area, and it diverts the flow and creates a alternate route for the flow that's like now lowered in pressure, so that the bile just drains normally through the biliary system rather than draining out into the abdomen. Okay, and now the last case is case 3. So it's a 72-year-old male who's day 1 post-laparotomy and adhesiolysis for a small bowel obstruction. So he had a past medical history of a Hartmann's for an obstructing sigmoid cancer 3 years ago. And he has low urine output and is tachypnic. So I guess just to explain that a bit further, he's had a small bowel obstruction and it's probably caused by adhesions from previous surgeries. And when you assess his A to E, his airway is patent, his breathing is a bit concerning, his respiratory rate is up, his oxygen saturations are a bit decreased, and he's having reduced breath sounds on his right lung base. His heart rate is normal, his blood pressure is normal, and there's no real other concerns from a circulation point of view. He looks to be warm and well perfused. He's alert and orientated, and his temperature is normal. But he hasn't had any urine output for the previous 8 hours. When you move on to history and examination, he says he's feeling increasingly short of breath. He doesn't have any chest pain, palpitations, or dizziness, but he's just finding it more and more difficult to breathe, and he's having lower abdominal discomfort. You examine him and he looks quite pale. He has an NG tube in situ, so for patients with bowel obstructions, we put an NG tube in, usually preoperatively, actually nearly always preoperatively, to decompress and also provide relief for the nausea and vomiting and allow gastric and biliary contents to drain. So it's on free drainage. His stoma bag from his previous Hartmann's is empty, but the stoma site looks healthy. He has some pain suprapubically. His laparotomy wound looks clean. His heart sounds are dual. No murmurs heard. He's got reduced air entry to that right base, but no crackles or wheeze. His calves are soft and non-tender, and his mucous membranes are moist. JVP not elevated, but he has some mild peripheral edema. He doesn't look dehydrated, maybe almost a little fluid overloaded. So at this point in time, maybe pause to see what you think might be going on from the information I've given you so far. Then when we find some extra information, we find out that his operation went to plan. So it was about an hour-long procedure with some adhesiolysis. There was no need for any bowel to be cut out. It all looked healthy and viable. His regular medications, so he's had a previous NSTEMI for which he's been put on metoprolol, candesartan, atorvastatin, aspirin and clopidogrel, and that NSTEMI happened 9 months ago. He's on apixaban for AF, and he has type 2 diabetes, so he takes metformin. The apixaban has been withheld for a few days prior to surgery, allowing it time to wash out. His respiratory rate has been uptrending throughout the day, and he had an IDC in situ during the operation, but it was removed So differentials at this point. In terms of the shortness of breath, I think atelectasis would be my primary differential. He's got reduced air entry to that right base, he's tachypneic, and his oxygen saturations are decreased without tachycardia and without chest pain and fever that we might be expecting more in a pneumonia. He's day 1 post-op, so it fits with the timeline as well. You should always think about PE. I think it's quite early on for this patient, but he does have a cancer history, so don't rule it out at this stage. He could have an NG in the wrong place, and considering his cardiac history, he may have some degree of heart failure, and these medications may have been withheld or not absorbed properly around the surgery. He also has some mild peripheral edema, so always think about him having some degree of heart failure and fluid then sitting in his lungs. However, there were no crackles heard, so keep it as a differential, but I don't think it's my primary one. In terms of reduced urine output, you should always think about pre-renal, post-renal and renal causes of low urine output. For him, I think I'll be leaning towards urinary retention as my primary differential because he hasn't had urine output for 8 hours. He's had a very recent operation, and this can cause people to have difficulty urinating. It's actually really common amongst surgical patients. He could be dehydrated and having pre-renal failure. However, on fluid assessment, he seemed to be well hydrated, and he doesn't have any signs like tachycardia and hypotension that may be consistent with hypovolemia. He's on metformin and also likely had contrast given for his CT scan to assess for his bowel obstruction earlier in his admission. So consider an acute kidney injury that may have resulted from that also may be causing low urine output. Investigations. So again, same thing, bedside, bloods, and any cultures or imaging. So bedside tests for him would be a blood sugar, an ECG, and a bladder scan. And I think that a bladder scan is really important for you to assess for urinary retention because you can estimate the amount that's in the bladder and therefore pretty clearly determine whether they're in retention. You can, for the bloods for him, I would do a full blood count, EUC, CRP. You want to assess his oxygenation, so I think an ABG is probably most useful in this circumstance, but depending on what your team and kind of hospital prefers, you may also use a VBG. He could have a chest x-ray, he should have a chest x-ray and discuss with your registrar. If you're really concerned about a PE, you could do a CTPA. I don't think it's the most likely cause in this patient, so might not score himself one, but keep it in the back of your mind and maybe ask for further advice about this. In terms of investigations, blood sugars 4, ECG shows Q waves and leads V2 to V3, that's consistent with a previous MI. Bladder scans shows 750 mils in the bladder, so that's pretty clearly showing you that he's in urinary retention, especially because he hasn't urinated in the last 8 hours. Bloods, full blood count and CRP look okay. His creatinine is 155 and it was previously normal, so he has a degree of acute kidney injury that you should definitely continue to monitor. It may be worsened by the urinary retention, but you should definitely look at his kidney function and continue to monitor it and his fluid status over the next few days. His ABG is normal. You do a chest x-ray which shows collapse of the right lower lobe with a small right-sided pleural effusion, so it looks like he's had some atelectasis, and a CTPA is decided not to be performed, probably because it's not the most likely diagnosis in this case. However, keep it in the back of your mind, and he may need one in the future if this doesn't resolve. To manage this patient, in terms of the shortness of breath and atelectasis, you should give oxygen to aim for saturations greater than 95%. So for this patient, it's probably just going to involve him having nasal prongs. He should have chest physiotherapy encourage him to mobilise and sit out of bed. You really want to avoid him getting a pneumonia, so as much as possible he needs to be mobilising and deep breathing. For that, you need to ensure that he has adequate analgesia. Often when patients have had a big abdominal surgery, the pain caused in their abdomen means that they breathe quite shallowly, and that can mean that the lung bases collapse. So you want to make sure that he has adequate analgesia so that he can deep breathe. He should have a catheter inserted fairly urgently to relieve this urinary retention and continue to monitor his urine output. He should have IV fluids continuing to be administered because he's nil by mouth, but he needs to have strict fluid balance, so you should be making sure that all his inputs and outputs are accurately recorded to make sure that he's not becoming fluid overloaded, because he's at high risk of this happening given his cardiac failure and his AKI. Thanks so much for listening to the presentation. I hope you found it helpful. Feel free to email me with any questions you might have. My email is there below. Thanks.